Good evening, everybody. Good evening. It's 9 o'clock on the dot, and it's time for Hope and Action Network's Friend of a Wounded Heart program. We warmly welcome you to this program this evening. Wednesdays, as usual, they're hard days for me, but I'm energized as 9 o'clock approaches because I know that I'll be meeting with you wonderful people and we are going to be discussing very interesting topics. But before we begin, let me say a word of prayer. Heavenly Father, we thank you for this evening. You took us through today safely. You brought us to this hour, and we pray that you take control of what transpires here this evening. May we all be edified. May we learn, and may we apply what we learn to our lives. We pray that you be with the presenter, give her clarity of mind. We know that she is a professional, but Lord, we still ask you to take control. Be with the connectivity, keep it going so that we can truly benefit from what transpires here. And we thank you for what you will do in Jesus' name. Amen. So welcome, everybody. I hope you shared the invitation so that other people can benefit from what we're doing here. But why are we here? Why do we come on every Wednesday night at 9 o'clock? Now, it's because Hope and Action Network has a vision. And the vision says a better society built on strong foundations through the empowerment of everyone. So whatever the topic is, we are aiming at empowering people. And for those of you who were with us along the way, you know we discuss any topic. We discuss love and marriage. We discuss crime, fake love, social issues. We talk about the children and the love for material things. We talk about living like the Joneses. Remember, we did the young girl, wear your size. This is when we were telling the young ladies to dress well. But let me just go back and tell you what we did for the last 5 sessions. You see, I'm not able to tell you about everything we did because we were here 144 times before. It's impossible to list those topics for you. But for the last 5 sessions, we did an August 20th turn of the tide, and we talked about how relationships could be healed. Sometimes the relationship is going sour, but it does not have to remain like that, doesn't have to continue like that. Then on August 13th, we did 7 times, and there we spoke about a young girl who ran away from home for the 7th time. And we were examining the reasons why children run away. And we said sometimes they're running from certain things, and sometimes they're running to certain things. On August 6th, we had Abel Alexis tame that temper, and she gave us some really, really good tips related to how we could deal with our temper. On the July 30th, Sylvester, the love man, Sylvester gave us 7 reasons why men leave their wives after so many years. And there's a part 2 coming. He's coming again to do part 2. On the 23rd of July, we did All That Glitters Is Not Gold. And there we were saying, be careful, examine things properly, because sometimes when we think we're getting gold, it's fool's gold. And we were not talking about gold itself, but we were talking about some choices we make that could be detrimental to us. This evening, though, our topic is quite a big club, quite a big club. You see, I usually research the topics that we're going to do. And then I found this quotation from Prince Harry. And he said, the experience I have had is that once you start talking about experiencing a mental health struggle, you realize that actually you're part of quite a big club. You see, sometimes people think, well, it's just them. And sometimes we think it's just the other person. But he says it's quite a big club. And we're saying that everyone will experience some challenges or struggles with mental well-being at some point in their lives. And just as everyone experiences challenges with their physical health, we have to pay attention to what's happening with our mental health. We have to acknowledge those challenges and we have to seek appropriate help so that we could have some positive outcomes. So we have with us this evening a professional, Dr. Alina Williams, who willingly accepted the invitation to come and to chat with us about mental health. I am handing it over to you now, Doc.
Okay, thank you very much.
You're welcome. You're welcome.
Okay, so if you just allow me to share my screen so that I could share my presentation, right?
Yes. So you should be able to do it now. Great.
Okay. All right, everybody could see my screen. You could see my screen, Doc?
Yes, clearly.
Nice. Okay, so good night, everyone. I'm Dr. Lena Williams. I'm a clinical psychologist for the past 15 years. I have worked with patients both publicly and privately at different institutions. During this time, I would have been responsible for diagnosing, assessing, and treating a wide range of mental health challenges and mental illnesses. And I would have also been allowed to serve on a lot of committees. I'm currently on the Ministry of Health, Mental Health and Psychosocial Support Committee, as well as the subcommittee that deals with suicide prevention. And suicide has always been interest of mine. It's an area of specialty for me, right? So my topic today will cover that. And I've tried to make the information as digestible as possible. So it's not very clinical. And I hope that at the end we could have fruitful discussions on it. So the objectives I have for us today, I would like to firstly differentiate between mental health and mental illness. I think that's an area that a lot of people don't understand. Then I would look at understanding risk and protective factors as it relates to our mental health and suicide. I will define what suicide actually is and examine the current rates and trends that we've observed globally as well as within Trinidad and Tobago setting. Help you to understand warning signs and safe responses to those warning signs, and as well as develop and identify practical actions that we could take in our fight against suicide. So when I talk about mental health, in general, we define mental health as the cognitive, behavioral, and emotional well-being of a person. So mental health comprises three core aspects. The cognitive aspect refers to how we think. The behavioral aspect is, of course, how we behave, how we act, what we choose to do or not do. And the emotional aspect is how we feel. And our mental health comprises these three. And if any area is compromised, then our mental health is compromised. According to the World Health Organization, our mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. And so in order for us to actually achieve these things, we would have to be able to think right. And thinking right means being able to have rational thoughts, being able to make decisions that are in line with our rules in society, that are in line with the goals we have for ourselves. We have to have a sound emotional health. So how we respond to things, how we feel about situations would need to be regulated and managed. And then, as I mentioned, in terms of our behavior, what we choose to do and not do. Now, mental health is very different from mental illness. I think what happens is a lot of people say, well, I don't need to be concerned about mental health because I don't have a mental illness. It's important to know that the absence of an illness is not the indication of health, right? And if I could use the example of physical health, we all have physical health and we all have a range of physical health. But the absence of an illness does not necessarily mean that we are physically healthy. So I'll get into that soon. But to define mental illness is essentially a mental health condition or disorder that affects our mood, our thinking, and our behavior. Now, the term mood is used here versus emotions because emotions fluctuate, whereas our mood tends to be very stable. So, if you think of the weather system, weather patterns, if you look at America, for example, it could be summer and we expect hot temperatures in summer, but summer doesn't mean that there will be no periods of rain, right? Same thing, it could be winter, but it might have one hot day in winter. So emotions fluctuate, mood is stable. So if it affects your mood, then it's linked to mental illness, right? And examples of mental illness would include depression, anxiety, schizophrenia, eating disorders, addictive behaviors, just to name a few. In order to be diagnosed with a mental illness, you have to be able to meet specific criteria that are listed in the DSM, which is the Diagnostic and Statistical Manual. It's the book by which clinicians will diagnose mental illnesses. And only upon meeting the criteria for these illnesses and it's being demonstrated to affect your functioning, your daily functioning, your daily life goals, can we say that a person has met the criteria to be diagnosed with a mental illness? So if we take, for example, physical health, there would be days you'll be good and you will not be experiencing any symptoms. We'll say that you're physically healthy. On the one occasion, let's say that you forget to eat or you're not eating on time or something has happened, you might find that you have a headache. Now, if you have that isolated headache, you won't go on to say, I'm a migraine sufferer. You won't go on to say, I suffer with migraine. You won't make that statement based on having one isolated headache, which was brought on by something that maybe you did not eat on time, etc. Similarly, if you have a period where you've experienced headaches, you might tell yourself you're having headaches frequently. It might be stress related, it could be work related. But again, unless you have met certain criteria, you've been diagnosed by a doctor, you still can't say that you have chronic migraine. But if you meet specific criteria for having migraine, it's affecting your daily functioning, your ability to achieve your goals, then a doctor would be able to say your physical health is compromised and you now do have an illness, right? So to explain this point clearer, I would like to demonstrate the mental health continuum. And this continuum is important because it demonstrates that we all have mental health. We may not all be mentally ill. So at the green zone, which is the area of normal, healthy functioning, this is the zone you could say living your best life, right? You are having normal mood fluctuations. You have consistent performance at work, at home, with your friends. Your sleep patterns may be normal. You're physically and socially active. You're confident with yourself and you are okay. If something happens, and this something could be something small, it could be something big, what happens is you enter the yellow zone. The yellow zone is the reacting zone, and it's common, but it's also reversible. At this zone, however, there is something present, whether that is external to your environment or internal with you, hormones, for example, that is impacting you and causing you to respond to some situation that is affecting or can possibly compromise your mental health. At this point, you're still not mentally ill, but your mental health is compromised. And when you are in this yellow stage, what you do at this stage determines whether you go back to the green zone and you return to healthy, normal functioning, or you suffer psychological injury and you now progress to the injured zone where you have significant functional impairment. Now, note at this zone, you're still not diagnosed with a mental illness. But this zone signals that things are becoming more critical. So, for example, irritability and impatience now turns into anger or anxiety. A tendency to have difficulty sleeping might now manifest as prolonged sleep disturbance. You're not able to fall asleep at all or stay asleep. Intermittent withdrawal from friends now becomes prolonged avoidance of social situations or withdrawal. Again, at this orange zone, the decisions that you make can take you out of this zone and allow you to move back to yellow and green. However, sometimes things happen, and once a person is in the orange zone, they progress to the red zone, at which point they are perhaps usually diagnosed with a clinical disorder. The symptoms that they experience in the red zone is severe and persistent, and thus enough to impair their functioning and disrupt their ability to live in their day-to-day environment or to carry out their day-to-day activities, right? So now anger and anxiety might become significant difficulties regulated emotion. Sadness progresses to depressed mood, and that is definitely more significant than the normal sadness people experience from day to day. You might find that they have disturbances in their thinking, so their thoughts become very irrational or very disruptive, and it can progress, for example, to having suicidal thoughts, intent, or behavior. The thing with our mental health is that unless we are very stable in the green zone, we never really know what will push us to move across the different zones. So, for example, if I am in the yellow zone right now, I don't know what is that straw that could break the camel back, that could take me to the orange zone, and then also take me to the red zone. And that's why being aware of our mental health is very important, because at any point in time, we should be making efforts to be in the green zone as consistently as possible. So, our mental health, as I said, it's comprised of three things: how we think, how we feel, and how we behave. But there are three factors that determine whether we develop a mental illness or not, or how our mental health fluctuates in our day-to-day functioning. And this is the biopsychosocial model. It essentially purports that our mental health, even our physical health, is the result of a combination of biological, psychological, and social factors that interplay with each other to determine how we respond to our environment or how we respond to different experiences. So, when you go to the doctor for any condition, one of the first things they'll ask you is, do you have a family history of diabetes? Do you have a family history of cancer? And that's because many illnesses have a genetic component. So there are genetic vulnerabilities that exist with many mental illnesses like bipolar disorder and schizophrenia, but there are also biological factors at play. So, for example, your gender, there are some illnesses that are more common in women than in men. There's also neurochemistry and immune functioning. So, our thyroid, for example, is closely linked to our mood. If your thyroid functioning is disrupted, you find that you have disruptions in your mood as well. We also look at psychological factors, and this refers to like your attitudes, your belief, your self-esteem, how you think about yourself. It also refers to how you see life. Are you generally optimistic or are you generally pessimistic? Do you have good coping skills when difficult situations arise? Do you generally handle it well? Are you resilient or do you break down? Do you fall apart? Your personality. Are you amenable to change? Are you adaptable? Or are you very rigid, inflexible? Do you find that you get on well with others or not? And then we look at the social context. And this refers to like your socioeconomic status, because of course your socioeconomic status determines many things, including access to healthcare and access to resources. your family background, your education, and the social support that is available to you, which could be your family, friends, church, community, etc. So somebody might say, two people went through the same thing. One developed mental health condition and one was fine. And it's not necessary that the situation itself is enough to say that because X happens, then Y is the outcome. We know that things have to be they have to line up correctly for your mental health to either be sustained and you have healthy mental health, or for it to be compromised and you become mentally ill, right? So again, examining your biological history, examining your own attitudes, doing introspection and looking at your surrounding, where you work, your family, your community, and determining whether these things are actually supporting you or they are diminishing your capacity to have good mental health is important. And using this model as well helps us to treat any disruptions in mental health. So, from the biological standpoint, we look at medication management if it's necessary, and not just psychiatric management, but it could be managing your thyroid, managing diabetes, because your physical health is linked to your mental health. From a psychological perspective, it might mean talking to someone, doing individual therapy, group therapy, being able to examine your thoughts, leaning into your own personal resources. And then in your social context, it might mean reaching out to people in your environment who could support you, but it might also mean bettering yourself through higher education, and helping your socioeconomic status to improve. So, as it relates to mental health, we always speak about risk factors and protective factors because ideally you want to know where you stand. And this is not an exhaustive list, but this list comprises the significant risk factors for developing a mental illness. But please note that even if you don't have a mental illness, these are also risk factors for your mental health being compromised. And that means being in the yellow or orange zone, right? Where you could be suffering injury. So, of course, number one, a family history of mental illness. If you have a family history of mental illness, it's likely that you can be more susceptible to developing a mental illness yourself. Having chronic physical illness or being in pain constantly is also a significant risk factor. And having a substance use problem can also make it likely that you will experience a mental health condition. From a psychological, emotional perspective, low self-esteem or poor coping skills. So life is stressful and we are always in a situation where we have to cope with something. So if your coping skills are poor, if your ability to bounce back is compromised, then you find that you will not be able to handle the small things in life. And those things could pile on, or you may have an experience where something very big happens and you don't have the emotional muscle to tolerate it. A history of trauma, abuse, or neglect is also very high on the list. Having stress, especially without support, and this is why we notice mental health being compromised in single parents or in postpartum women. Unresolved grief or loss is also very significant, and can lead to numerous complications later on. And then from a social environmental perspective, poverty and financial hardship is definitely high on the list. Unemployment or having an insecure job or having very limited job prospects, exposure to violence, crime, or disasters, having very weak support systems. So there are so many people, even within Tobago, that go through situations alone. Like literally, they have nobody to turn to, they have nowhere to turn to. Maybe they do have access to resources, but because of their psychological makeup, they may feel like they can't trust anyone. Their emotional background may be one where they've been exposed to trauma or abuse in the past, and so they become very withdrawn from seeking help from others. And so social isolation is actually one of the highest risk factors for developing a mental illness, or having weak support systems is linked to a poorer prognosis were you to transition through the different zones of mental health. And then, of course, there's bullying, discrimination, or stigma. When we consider risk factors, we always consider protective factors. And you also want to look here at what do you have in your life built in right now that is protecting you from developing a mental illness, or is protecting you from transitioning through the different zones, or if you were to develop a mental illness, would allow you to move out of the ill zone and back into injury and healthy. And so, from a biological perspective, you cannot have good mental health if your physical health is not good. So, your physical health is very strongly tied to your mental health. The mind and the body are connected. So, people that engage in regular exercise or eat healthy would normally be sort of protected from exposure to mental health conditions or something to happen to them, right? Now, I mentioned biological. I want to highlight here healthy sleep, because our sleep is usually one of the first things to be compromised when our mental health is not well. So there are some people that will come in my office and they'll be like, Doc, I good, I have nothing to complain about, everything all right. But when I ask them about their sleep, they will tell me they're not falling asleep, or they can't stay asleep, or they go to sleep, but they wake up like 2, 3 o'clock and then they can't get back to sleep. And so if your sleep is drastically compromised, it means that you may not be in the green zone that you think you're in. You could be in yellow or orange, right? From a psychological, emotional perspective, having a good self-esteem, a positive sense of self, like you know who you are secure in your identity, you know what you want, those things work for you. Being strong, having good resilience and adaptability. Being adaptable is very important, because um, what we find is that a lot of people try to control their environment in an attempt to mitigate having mental health issues, but actually control puts you at risk because there's very little that we can control. So being adaptable is actually better. You want to also access treatment if you notice problems arising, and you want to do so if you know especially that you are at risk. So you have a family history, let's say. Effective coping skills are important. And in general, people that are optimistic are more likely to remain in the green zone than people that are pessimistic. From the social environment perspective, having a supportive family and close relationships is the number one protective factor for mental health, um, even higher than physical health. So if you go through something and you have good friends, good family members, good co-workers, you have people that can buffer you from the full impact of that stressor, then you are well on your way to having good mental health. But if you don't have a supportive environment, you're definitely at risk. Safe and stable living environment is also very important for mental health, as is access to good education and healthcare, of course. Feeling like you're part of a community is also very important. And this could be like your community itself, like if you have a community, a close relationship with community members in your village, but it could also be like an NGO or an organization or a church, right? But having social support networks is important for protecting your mental health. And then being able to feel like you are part of the general um, population, so through acceptance, inclusion, and the reduction of stigma. And these are all things that determine how you move through the mental health continuum. Okay, are there any questions? Doc, should I take questions
Yeah.
now or should I wait until after?
No, Dr. Williams, you may
Go
ask
ahead.
now.
Okay, does anybody have any questions before I go on? No? Okay. So now I want to talk about suicide. And let me say that the definition of suicide has changed over the years. I felt it necessary to include the evolution of the definitions, but we currently use the CDC or the National Institute of Mental Health definition. But initially, suicide was defined as death from injury, poisoning, or suffocation, where there is evidence, either explicitly or implicitly, that the injury was self-inflicted and that the decedent intended to kill himself or herself, right? Later, it was redefined to say that suicide is death caused by self-directed injurious behavior with intent to die as a result of the behavior, and then later shortened to death caused by injuring oneself with the intent to die. So there are two things that are significant here. One is that there must be death involved, and two is that the intent has to be that the person wanted to die. So if someone let's say someone ingested something, but their intent was not to die, it will not be classified as a suicide, right? We have to know that the intention was to die, that the behavior was purposefully chosen by this person, and that is why the NIMH defines it as self-directed. I am choosing to do this. The intent is to die, and the result was death. And that is essentially what suicide is. Now, the effects of suicide is wide-reaching. So suicide is not an individual problem. And I think if we reframe suicide as being an individual problem, our suicide prevention strategies would be better. It would be better in terms of how we can reach people in society. One of the issues I face being on the suicide subcommittee is the perception that if I don't have a mental health challenge and I don't have a mental illness and I'm fine, then suicide is not my concern because I don't want to kill myself, right? But the thing is, suicide doesn't just affect the person that has died. Every suicide leaves behind a circle of people grappling with grief, guilt, and unanswered questions. Suicide is actually a major public health concern that has far-reaching social, emotional, and economic consequences, and it's a huge global concern. So the American Association of Suicidology estimates that one death by suicide affects up to 135 people. This would include the family, the immediate family, distant family, friends, co-workers, colleagues, associates of that person, right? And of the 135 persons affected, at least 6 persons may develop a serious mental health condition due to the impact. So it's not just that this individual has a problem, but suicide itself is a public concern. It's estimated that about 800,000 people die by suicide every year. So globally, every 40 seconds, someone dies by suicide. I'm not able to see how long we've been. Okay, so we've been on this session for about 30 minutes now. And every 40 seconds globally, someone dies by suicide. So you can calculate just in this time that I'm taking to educate you about mental health and suicide, how many persons have died globally. And the startling statistic is that for every suicide recorded, at least 20 to 40 non-fatal attempts have been made. We'll get into this a little bit more, right? So overall, Trinidad and Tobago ranks 75th out of 182 countries where suicide is concerned. We are third within the region after Guyana and Suriname. And we are really not too far from Suriname. We have seen an increase in registered suicides from 2019. And I'm specifying registered because there are many deaths by suicide that are not registered as suicide for various reasons, right? So in 2019, we had 92. In 2020, 104, in 2021, 128, in 2022, 142, and 154 in 2023. I had the numbers for 2024. I know it's higher than 154. I believe it was 172 or 196, but I didn't put it here because I didn't want to misquote the number. However, I could always share the number at a later date. And for 2025, we have had a high number of suicide deaths as well. So I just want to go into some trends and let me ask you all.
I would like to ask a question.
Sure.
I would like to ask a question.
Sure.
It will be two form. What caused people to commit suicide? Is it will it more men or more women? That's my question.
Okay, so I'm going to get into that. But since you're on the mic, then you tell me what you think.
I believe men.
Okay, all right. So yeah, so I asked, are women or men at higher risk? When we examine the literature, men are likely to die by suicide, but women are likely to make more attempts. So men are 3 to 5 times more likely to die by suicide, but women are 2 to 3 times more likely to attempt suicide. So the numbers are staggering. More women attempt suicide, but more men die by suicide. Would anyone want to share why they think that is?
Most women who attempt suicide, they are not trying to kill themselves. They are just trying to get some attention. And that's the main reason.
Okay. So I will come back to the getting attention. I'm going to talk about that. But what happened is, statistically speaking, women often access help sooner. They do have more outlets to speak out about their issue. And in general, women tend to choose less violent and lethal methods, which means that they are more often than not rescued during their suicide attempt. So what we know globally is that, and even within the Trinidad and Tobago context, most men will use lethal methods that include ingestion of insecticide, hanging, or gunshot. And women tend to choose outlets that would include overdose. So they tend to overdose on tablets, or they will tend to self-harm through cutting. The thing with overdosing is that there's a window by which this woman could be found and taken to the hospital and rescued. Whereas for a man that chooses hanging or a gunshot wound, there isn't that window available to them, right? When we look at suicide in young people, currently suicide is the 4th leading cause of death in the age group 15 to 29 years old. And it's increasing because in some countries, suicide is the 2nd leading cause of death in young people. So just think about that, as in of all the things that can cause death, right, which could include motor vehicle accidents, murders, cardiovascular diseases, neuro diseases. Suicide is the way that a significant number of young people are ending their life. So what is happening? One, there's a rising rate of depression, anxiety, and self-harm among young people. There's a rising number of cases of bullying, discrimination, and silence around emotions. The influence of social media has made it very difficult for young people to adapt well to society and even to regulate their emotions, to have a fair understanding of life in general. We see a rise in cyberbullying, but also social comparison is quite significant. There are many young people online looking at Instagram models or influencers and comparing themselves to these people, feeling less than. This goes back to the psychological makeup of the individual, right? So it's affecting their self-esteem. It's affecting their ability to develop a secure identity. And this is also leading to the rise in suicide. And then, of course, there's economic and structural stress that young people face, which could be youth unemployment, poverty, as well as limited mental health access and long wait times. In fact, it's not as bad in Tobago, but in Trinidad, I could say that when a young person needs an appointment, sometimes the wait time could be 6 months to a year before they get an appointment. Now, imagine someone experiencing significant mental health distress, a 13-year-old or 14-year-old, having to wait 6 months or 1 year in the public system before they're seen. And this is where we talk about access to mental health treatment. Because if you're not able to pay a psychiatrist or psychologist privately, then it limits what your reach is in terms of getting help. Yeah? Okay, so before we continue, I just wanted to do a little myths versus facts. I'm going to ask you some questions and you just respond to yourself. So you don't have to unmute your mic or anything. I just want you to think about it and think of an answer, and then I will share what the answer is, right? Red is for myths and green is for facts. So the first thing, talking about suicide will put the idea in someone's head. I just want you to think about it. Is that a myth or is that a fact? Talking about suicide will put the idea in someone's head. Okay, so it's a myth, right? It's a myth that if you talk to someone that you suspect may be having suicidal thoughts, that you are actually going to put the idea in their head. If someone is depressed, if someone is struggling, chances are they've already thought about it. So asking them directly about their suicidal thoughts can actually save their life. And I know this is difficult, but you really don't want to beat around the bush if you're asking about it. So if somebody expresses that they're going through something, even if they have not indicated that they have intentions of hurting themselves or dying by suicide, you want to come straight out and ask, hey, you've mentioned that you're going through this breakup and you seem really affected. At any point in time you thought about killing yourself? Literally, you want to be that direct, right? Okay, many who die by suicide communicated intent beforehand. Myth or fact? And that's a fact. So many people who die by suicide actually would have communicated either indirectly or directly with people around them that they had intentions of doing so. The numbers are as high as 85%. In fact, there's research that shows that up to 66% of people that died by suicide would have communicated to someone within the past 3 months, the 3 months preceding the suicidal action, that they were thinking of or contemplating suicide. So it's very important to, again, pay attention to indirect or direct communication. And again, that's why we go back to the first point, which is you ask directly. Are you thinking about suicide? Are you thinking about killing yourself, right? Only people with mental illness consider suicide. And that's a myth, right? So anybody that has a compromised mental health can consider suicide. And remember, we spoke about the 4 stages. So it's unlikely you'll consider suicide if you're in the green zone, but in the orange, in the yellow, and in the red, those are the areas where your mental health is compromised. Your mental health consists of your ability to think, to feel, and to act. So if your thinking is compromised, it's likely that you may not see options or resources that are available to you. Your thinking might lead you to believe nobody cares about me. Your thinking might lead you to feel worthless or to feel as though you're not included. So you don't necessarily have to be diagnosed with a mental illness or even meet the criteria for a mental illness to consider suicide and die by suicide. Number 4, people who attempt suicide are seeking attention. Myth or fact? So that's actually a myth, right? People that attempt suicide are in emotional pain. and in deep crisis. And I will get to a few slides down, I think it's the next 2 slides, I will get to why it might appear that they're seeking attention. But the truth is, anyone that makes an attempt on their life, that makes an attempt to harm themselves in any way, even if it appears on the outside that it wasn't something that could be fatal, anybody that takes such actions that is self-directed and injurious is in fact in deep emotional pain, right? Suicide is preventable with timely intervention and support, myth or fact? And that's fact. So suicide is very preventable, and what determines the outcome is usually when the intervention is timely, which I will get to in that same slide, and how the support is given to that person, the access to resources that they have. And the support here could be institutional support, so the systems that we have in place through, for example, like the public hospital, through the different divisions, but it could also be community support, familial support, financial support. Improvement after a suicidal crisis means the risk is over. And that's a myth, right? So it's a myth to think that because somebody went through a crisis and the crisis is over and they're feeling better now, and it appears that everything is fine, that they're no longer in fact considering suicide. One of the highest predictors of suicide is a previous suicide attempt. So you don't ever want to get complacent when you're dealing with someone that has had a history of attempted suicide, because it means that they may be particularly vulnerable to stressors that exist in their environment. And then myth or fact, suicide affects people of all ages, genders, cultures, and socioeconomic background. And that is a fact, right? And we could see that from the fact that there are many famous people that have died by suicide. For example, the actor Robin Williams, the handbag designer Kate Spade, even Anthony Bourdain. I think he was a very famous food critic, etc. It really doesn't matter who you are, where you come from, what gender, what age. Suicide affects everyone. Yeah. So let me just discuss some.
Can you take a question?
Yes.
I saw Glenda had a hand up a while back.
Sure.
Yes, okay.
She answered. I wanted to mention about, young people having these peer pressures and stuff, and she didn't mention those things, so I didn't bother anymore. Thanks very much. I'm enjoying it very much.
Thank you. Okay. So when we look at risk factors for suicide, there are those that we definitely have to be aware of. And as I mentioned in the slide previously, a previous suicide attempt is a significant risk factor for future suicide attempts, right? You never want to get complacent with the person and assume that because the crisis is over, it means that suicide is off the table. A history of depression or other mental illness, serious illness such as chronic pain, and this component here is why we actually find a high rate of suicide in geriatric populations. So they may get to the age where they're in so much physical pain. Chronic pain is very distressing, or they may have significant physical illnesses and they may contemplate suicide. Job or financial problems through loss or poverty is also a very significant stressor or risk factor. And I think it was maybe 2 weeks ago or a week ago in the papers, I would have seen a young man, 32 years old, that would have died by suicide because he lost his job. Substance use is also significant because substance use impairs your ability to think. It impairs your decision-making capabilities. Hopelessness. Now, this is something I always ask my patients and clients about. whether they have hope or not. And in the next slide, you'll see why. But hopelessness is a very, very important risk factor that you want to inquire about. So hope is what sustains us. It is what gets us out of bed and ready to face a new day. Having hope is what takes us through difficulties. And somebody in a state of hopelessness just does not have that drive in them to get through circumstances, right? Current or prior history of adverse childhood experiences, neglect or abuse. Trauma, the trauma could be sexual trauma, it could be physical trauma. It could be related to witnessing something or being directly involved in a traumatic experience. Bullying, loss of a relationship, again, very high in Trinidad and Tobago. Loss of a relationship is a significant risk factor for a lot of suicides that have happened in the country. And not just I'm talking about suicides, but remember, for every suicide, there are many more suicide attempts. So this include attempts as well, those that were non-fatal. Having easy access to lethal means of suicide is also significant. So I would usually ask my patients too, have you thought about killing yourself? And if they say yes, I will ask them, what have you thought about in terms of how you plan to carry it out? And if I have a young person that says, they'll shoot themselves in the head, but they have no access to a gun, then I tend to think, okay, the risk might be lower versus, let's say that the patient in front of me is a police officer and he says, I'm thinking about suicide and I think I'll shoot myself. Now the risk is high because he can easily access the firearm or the means to hurt himself. And then the unsafe media portrayal of suicide. So there is something known as contagion. And what happens is, depending on how the media portrays the suicide, sometimes it could be portrayed as something glamorous. And those that are in an ambivalent state, which I will get to, can actually think of the person as a hero and tell themselves, if they could do it, I could do it too. And so the media plays a very big part in how people respond to somebody dying by suicide. In terms of the warning signs, and this is important, you want to listen for somebody expressing hopelessness. Now, they may not directly come out and say, I want to die, but they may make certain statements that cause you to pause. And it might be something like you tell them, what's your plan for Christmas this year? They say something like, I don't know if I could be around for Christmas now. Or I'm not really thinking about Christmas because who knows what could happen. Those are things that you kind of have to pause and ask about, right? So even though the person may not directly say, I'm thinking about killing myself, you want to listen for any expression of hopelessness or a desire to not live. They may withdraw from family, friends, and activities that once brought joy. So you find you're reaching out to the person, they would normally respond to your WhatsApp messages quick. Now days passing and you're not hearing from them. When you do hear from them, is one-word answers. You're not seeing them active on social media as much as before. They're not willing to go out and engage with you. That's a significant thing, and it is a significant warning sign because withdrawing from people means that you have more time to live in your head. Your thoughts become loud. And if your thoughts are already compromised because your mental health is compromised, then it means that you may convince yourself of things that are not true. You want to look for drastic changes in the person's mood. So somebody that is normally very reserved and very calm is all of a sudden irritable, snappy, they seem to always be on edge. You want to look out for that. But similarly, if somebody is always very feisty and very energetic, and all of a sudden there's this sense of uneasy calmness about them, you also want to be aware of that. So you're looking at drastic changes that occur in any direction. You want to look for people that might be expressing feelings of being a burden. So they might say something like, I feel like my family would be better off without me, or, if I die, nobody ain't gonna miss me, that kind of thing. You want to listen out for that. You want to look out for people that are neglecting their appearances or they've lost interest in taking care of themselves, especially if they were very meticulous about their appearance and how they look. You want to look out for anybody engaging in risky or self-destructive behavior, so an increase in substance use, or they're driving recklessly and, their disposition is kind of like, well, we all had to death somehow anyway, or, if it happened, it happened. That sort of passive suicide ideation is also risky. If people are giving away prized possessions, so you find like they've started to settle affairs unexpectedly, you want to ask about that too. And again, do not ever be afraid to come out directly and ask about it, because you just want to be sure. So if somebody asks me out of the blue, Dr. Williams, if somebody dies by suicide, the family does still get the insurance. I would ask them, are you thinking about suicide? They could just be asking for interest's sake, but I'm going to ask, are you considering that? Because I need to know if you are trying to settle affairs or if you are trying to put plans in place for something that you're planning to do. You want to look at changes in sleep or appetite because mental health affects your physical health, and your sleep and appetite are two things that you can't fake. I don't know how many of you all have ever gotten a good tabanca, but when you get a good tabanca, you have no appetite. You don't even know what it feels like to be hungry. And that's because once your mental health is comprised to that extent, your digestive system shuts down, right? They may talk or write about death frequently, or, and this is a big one, they are suddenly very happy after a depressive episode. So sometimes that sudden improvement in mood, again, you sense there's this eerie sense of calmness despite what the person is going through. It could be a sign that they've decided on suicide. Yes? So let me get to why this happens now, because this is what everybody wants to know, right? And it's very difficult to understand suicide if you've never been in the throes of deep emotional pain. Let me say that from the start. Unless you've been there or you've spoken to enough people that have been there, you will never really understand what it's like to get to that place where you feel like there's nothing beyond life for me anymore. There's this very nice quote from a clinical psychologist that defines it well. She said, when people are suicidal, their thinking is paralyzed. Their options appear spare or non-existent. Their mood is despairing, and hopelessness permeates their entire mental domain. The future cannot be separated from the present, and the present is painful beyond solace. So this is what happens when somebody is contemplating suicide. It starts off with overwhelming pain. Now, you have to remember that while we have a lot of management options for physical pain, we don't have those same options for emotional pain. Think about it. If you're having a little bit of pain, what you do? You take 2 Panadol. If the pain is progressively worse, you might take something stronger. You might take ibuprofen, cataflam, you might take Panadine. If the pain is even stronger yet, you still have options. You might take morphine. You might take something like an opioid. There are options available to you that allows you to mitigate or remove physical pain relatively quickly and relatively easily. There are no such equivalent when it comes to emotional pain. Emotional pain is something that is quite persistent. And even when you talk to someone, the pain doesn't go away, right? Not, at least not as quickly as Panadol or Excedrin could take away a headache. So what happens is there's this overwhelming sense of pain, emotional pain for the person. And that pain becomes narrowed into a sense of hopelessness. When they feel hopeless, essentially it removes the possibility of options for them. You have to remember too that if you've never been there, you may not consider suicide an option as a problem-solving option, but it is an option, albeit a permanent one. Suicide is an option that is available to people. Once hopelessness persists and you are projecting into the future that nothing can improve, the person develops a tunnel vision. I want you to think about the horses that race. They wear blinders, and they wear blinders because the riders don't want them startled or distracted by anything external to the finish line. They just want them focused on getting to the finish line without having the ability to consider any options that may be available to them. So when they experience this tunnel vision, it reduces their capacity to explore options or resources that are available to them. Let's take Kate Spade, for example. She is the bag designer, right? Kate Spade had unlimited access to resources. She was famous, she was rich, she was successful, she had her family, she had many things going for her. But in tunnel vision, those things don't exist. Similarly to when the horses are racing down that track, you don't exist. Other people, other horses don't exist. The only thing that exists is the finish line. And so once tunnel vision is part of the person's way of thinking, their thinking is now paralyzed. They can only see this one option as their only option. The suicide risk increases. Remember, at this point, it is not what actually exists, it is what they have access to seeing exist, right? And what happens after? There's a concept known as ambivalence. And ambivalence is a state that permeates the person that is experiencing suicide. I can tell you from numerous interviews I've done with clients, with patients that have attempted suicide and the attempt was non-fatal, that at no point in time was anybody able to say to me, you know, I was really 100% sure that I wanted to die. Most times it's that I am 100% sure I didn't want to feel pain anymore. I'm 100% sure that there were no other options for me. I am 100% sure that I couldn't bear whatever I was bearing. But nobody was able to say no. I knew I wanted to die. Like, that is what I just wanted and nothing else. So many people that get to the end of the tunnel get to this crossroad, and this crossroad is known as the ambivalent state. The ambivalent state is the person that wants life, they want to have connection, they want a reason to live, but that desire is in direct combat with unbearable pain, hopelessness, and the sense that the only escape available to them is death. The good thing is that for us as clinicians and for you as people interested in helping others, ambivalence is the window of opportunity. Ambivalence is the point at which we can intervene, because at this point, the person has not chosen a path as yet. Their vision is narrowed, suicide is on the table. It's an option that looks very good, but it is not an option that they can say they are 100% invested in as yet. And so what happens is that when we see somebody that wants to end their emotional pain but wants to live, they may make attempts that appear that are non-fatal and thus appear as though they're seeking attention. As an example, I had a patient that she would have seen me because she would have attempted suicide. She would have made a suicide attempt. When we inquired about the suicide attempt, what she in fact did was she ingested 4 tablets, right? 4 Panadol or ibuprofen tablets. Now to the family, and it's unfortunate because this is how the general public sees it as well. They would say something like, well, if you really wanted to die, why you only take 4? Why you didn't take 20? Like, who going to die with 4 tablets? In essence, you are reinforcing for the person that not only are they hopeless, but they are now a failure because they feel like, I can't even kill myself, right? We don't want to reinforce that message. However, because ambivalence is a real state, some of the attempts may appear as not serious, but every attempt on life is serious, and we cannot conclusively say what is seeking attention and what is due to unbearable pain. Because choosing to end your life is a very significant decision to make, and it's a very painful decision to make too. You have to realize that at this point, this person is not considering anything else except ending their suffering. So there's no such thing as why didn't think about the children, or why didn't think about their husband or their wife, why didn't talk to me, why. There's the blinders on. They want to live, but they want to be free from pain. And because they cannot accomplish both in that moment, they have to make a choice. And for some, the choice is death. For others, the choice is life, while still inflicting some level of injury on themselves. Yes? Okay. So what should you do if you think someone is at risk? I've divided it into what to do and what not to do. So what you want to do is firstly encourage the person to seek professional help, because unless you've gone through the training that is required to diagnose and assess and treat this person properly, you don't want to risk causing more harm. And sometimes your intention may not be to harm, but harm comes about by what you say, as in the case with the person that would have taken the 4 tablets and the response was, you didn't really want to die. Right? Because now if they were to attempt the next time, they'll tell themselves, well, let me show you that I really did want to die. And they may take 30, thus preventing themselves from being able to be saved. You want to have them call a crisis line for advice or make a referral where appropriate, and be proactive. This is not a time for you to watch and see. You have something come up on your skin, you might watch and see, let me see what happened, or you feel like a little tickle in your throat, you say, I wonder if I get in the cold, let me watch and see. Suicide is not the time for you to be reactive. You need to be proactive and start engaging and mobilizing professional resources. You want to listen. Let the person unload onto you if you have the capacity to hold space for them. Let them unload their despair, their anger, their confusion, their sense of hopelessness, whatever it is. Let them unload and keep them talking. Because as they talk, the ability for the blinders to shift a little may happen. You don't need to say anything profound at this point. You literally just need to let them talk. Be non-judgmental, patient, calm, and accepting. And the accepting here is not accepting of their decision, it's accepting of their emotional pain, their crisis, the hurt, the injury that they may feel. Offer hope where possible through resources, tangible resources. So this is not time to sprinkle fairy dust or anything like that. You want to offer tangible hope to this person, and take the person seriously, please, because again, even us as clinicians, we cannot decipher when somebody is about to make a serious attempt or not. We have to take every suggestion, every spoken word about how they feel very seriously. What you don't want to do is argue with them. It is not the time to say things like, but look how much things you have going for you, or, why you want to do that, get a new job, or look how much money you're making, or it's not the time to reason with the person. You bringing in evidence that appears rational to you is going to fall on deaf ears to a person that has tunnel vision. So it's not the time to make an argument or make a case for why they should live. You also don't want to act shocked. And I know this might be difficult, especially if you've never been in a position where somebody comes out and says that to you, but you want to regulate your emotion. So if you can, as much as possible, poker face and nonchalant. Oh, I'm sorry to hear that you're thinking about that. Tell me what's causing you to feel that way. As neutral as you can possibly muster, because acting shock can cause the person to clam up and not share what is happening. And you want information. You want to know if they already have a plan in place. Are they thinking to do it Friday at 3 o'clock when nobody's home? Have they thought about doing it Sunday when everybody go to church? You want to be neutral, so it leaves the room open for them to talk. It's not the time to give a lecture on the value of life, whether it's a crime or not, whether it's a sin or not, what God will do or not, if they're going to go to hell or heaven or not. It is not the time to do that. You work out your own salvation and allow them to go through a process that they need to go through. Bringing in morality issues at that point in time actually does more harm. It actually does not cause them to pause and say, hey, you know what? Yeah, God won't like this. Let me reconsider. It's not the time to do it, because then on top of what they're dealing with, you are introducing guilt and shame. And those are two big emotions associated with wanting to die in the first place. Do not promise confidentiality. It doesn't matter how many times they ask you to be to not say anything to their loved ones. It doesn't matter if they say, I'll never talk to you again. It doesn't matter if they say, I'll never trust you again. It does not matter when somebody's life is on the line. You do not promise them confidentiality. You do all in your power to break confidentiality and to save the person's life. You inform their next of kin if you have access to next of kin. You inform somebody that is close to them. If it's a child, you inform the parent. If it's an adult, you inform their spouse. You could inform their employer, their boss, whatever. Inform somebody, because it's not the time to keep secrets. And don't blame yourself for any outcome that happens. Unless you know you really intentionally acted maliciously, then you have to give yourself grace, because it is a very difficult thing to navigate. And the last thing I want to talk about is we've had a number of recent deaths by suicide in Tobago. I know it is also very prevalent in Trinidad. And so I just wanted to share with some of you how you could help family members or friends, co-workers, etc., navigate the loss of someone with suicide by suicide. The first thing you have to allow them to do is to learn to live with unanswered questions. And the truth is, we will never have the answer to these questions. We will never understand what it is like to be in the current state, or to be in a state where you really have concretized the decision to end your life. Now, there's this very interesting video. If you go on YouTube and you go on YouTube and look for Golden Bridge Jump Suicide, something like that, there's a video with a guy. He is now an advocate for suicide prevention worldwide. But years ago, he went up on top of the Golden Gate Bridge and he decided to end his life. He held on to the bridge and he jumped off. And in his videos, in all his presentations where he educates the public on suicide, he says the moment his hands left the railing, he knew he made a mistake. Or up until that time, he was convinced that his family would be better off if he was dead. Nobody loved him. He felt like he was worthless. And he also had a mental illness. He had schizophrenia and he was hearing voices. But he said the moment his hand left the railing, he knew he made a mistake. Here's the thing. It's very difficult to fully understand suicide because the people that we need to help us to understand suicide are dead. And so we have to rely on people that have survived or have had a non-fatal suicide attempt. And so we don't have all the answers. We'll never have all the answers. Even with all the research, we'll never truly know what it is like to be at that stage. And people have to come to that place of acceptance where they will not have the answers. Acknowledge feelings. You will feel betrayed, confused, angry, hurt. There'll be despair. Why didn't this person reach out to me? Why they didn't message me? Why this? Why that? How come I didn't see this? They didn't say anything. How they could do something? Why they so selfish? Acknowledge your feelings, but recognize too that this isn't about you. And the person in that moment had a compromised thought pattern. This compromised thought pattern meant or means that they could not make decisions even with information that appears to you to be quite available to them. Turn guilt into forgiveness. So allow whatever guilty feelings the person has to be translated into forgiving, whether it's the person or themselves, right? Accept the loneliness that comes from the death of someone due to suicide. And okay, so let me explain what I mean by the loneliness here. When we lose someone to cancer, to some physical illness, let's say, something very traumatic too, like a car accident, you find that the community comes together and rallies around that person. You know, there's this sense of community spirit that takes place. But when you lose a loved one to suicide, there is a lot of shame and confusion wrapped into that loss. And so people are very hesitant about coming close to you. They don't know what to say, right? Especially if they have their own thoughts about suicide in terms of the morality aspect of it. So you may find that as you are grieving the death of a loved one by suicide, the people that you thought would be there for you, they're not there for you. And many times it's that you have to grieve this loss by yourself because people see it as, well, you make a choice. This person chose to die, and so I'm not going to mourn this person. I'm not going to be there for this funeral. And so it can be very lonely. You want to draw on spiritual resources because only God could provide the peace that you will need to get through some of those unanswered questions. And even if you go to therapy, even if you seek professional help, God is still really the only person that could provide the sense of peace that you need that passeth all understanding. And then you want to be patient with the pain that you have and patient with yourself. From a public health perspective, what we can also do is try to limit access to lethal means. So the agricultural store, somebody come in to buy insecticide, just ask them, you okay? You have a garden, you're planting something, tell me about your produce, tell me about your crops. I know that in times past, especially among the Indo population, there would have been measures put in place to try to limit access to insecticides because it was a very common means of suicide among the Indo population. And so having stores, having the persons in these agricultural shops ask questions about the intent of the insecticide, that is important. In young people, having limited access to means like access to firearms is very significant as well. You want to advocate for responsible media reporting, so call out people when they're not reporting responsibly. You want to help build life skills in young people because resilient people make for people that have better mental health, and it reduces the risk of suicide attempts. And then early identification and follow-up of those that may be at risk. And so you've learned about some of the risk factors tonight. For example, loss of job. If your friend loses their job tomorrow, you want in a few days to ask, hey, how you going? I just checking in. You know, losing a job could be very hard. And some people, when they lose their job, they think about ending their life. Those thoughts cross your mind. You want to identify anything. I can tell you that people that are contemplating suicide are one, ambivalent. Two, they want to talk about it. So if you ask, they would more than likely say, yes, I am thinking about it. Or in their reaction, you would be able to gauge. They might say something like, no, I'm not going to take my life, but girl, if I dead, I dead. That kind of thing you want to be able to identify and follow up on. And so these are the local resources available. There's Lifeline. These are the numbers, which I could leave up for you. Of course, 211 is very accessible here in Tobago, and you could call it. There's also findcareTT.com, and findcareTT.com has a directory with access to all the resources available in Trinidad and Tobago, public, private, that a person can seek help from. And there's, of course, the local health centers and the Scarborough General Hospital, where you can get information about how to manage both mental health conditions, illnesses, as well as suicidal thoughts and ideations. And that is the end of my presentation. So if anybody has any questions, they could ask me now.
There are two questions, Doc.
Okay.
One, the first one, help me to understand, if you love your children so much, how you kill yourself and leave them, knowing someone else has to be there for them and they will never be like you. What drives, as that young man in South who killed himself because he lost his job, left his little children behind. So I wonder, don't they love them at that time? Do they blank them out? What happens? Because it's so hard to think, that somebody could, parents leave dying, killing themselves and leaving their children. I could never understand it.
So that last point you made is actually the answer to the question. You can't understand it because you've not been at that point of despair. If you are trying to understand compromised mental health when you are mentally healthy, it's very difficult to relate to it. Now, remember, even in the green zone where you are mentally healthy, you have normal fluctuations in mood. These fluctuations in mood are not compromising your ability to think. But when you have a mental health injury, or if you're reacting to a situation, your ability to think is compromised. And so I mentioned one, hopelessness, and two, the tunnel vision. So let me give you an example of, this is a light-hearted example, but it's an example of what happens generally. On Sunday, I had decided that I was going to cook pilau for lunch. I made up my mind. I had everything out, chicken season, rice, everything, coconut milk, everything is laid out. And I come by my mom and I come to get something and she's like, oh, she's cooking pilau. So she asked me to cook something else because she's cooking pilau. She's like, if I have pilau and you have pilau, that doesn't make sense. You cook something else because I'm cooking pilau. And the thing is, in that moment, I felt like, but I already made up my mind. I had everything prepared to cook this pilau. And do I have access to cook something else? I do. I could have cooked curry chicken. I could have cooked anything else. Do I have the means to do it, the knowledge, the ability to cook something else? I did. I have the wherewithal. But in that moment, my vision was tunneled already. I had made up my mind since Friday to cook this pilau on Sunday. That even when she offered a reasonable suggestion of, well, if I have pilau, it doesn't make sense. You have pilau. I didn't take the suggestion and I still cooked my pilau. Both of us now have 2 big pots of pilau, right? That goes to say that even when the person has options available, even when there are external resources available, even when there is love available, the person cannot see anything beside what is in front of them. And what is in front of them is emotional pain, combined with a sense of no escape, a very grim, hopeless future. And so the answer in the moment is suicide. it's an option that remains on the table despite what else is presented to them.
Thank you. And the second question. Now you said, don't go moral and then. But what if you decide to hold that person, let them know you love them, and pray sincerely? Will that be wrong to be praying for that one that you know is about to kill his or herself? Because God can do anything. So I was wondering, as you say, don't go and talk moral talk. Can you decide to pray for them? Will that help?
What I would suggest is that you pray for them in your own time. I would suggest that you listen to everything they have to say. Even when there is silence in the space, you not say anything. And once you've sought appropriate help for the person, then you are free to pray for that person. But in the moment, I will not suggest it. It's not something I would recommend at all.
Give me a reason.
Because
I'll tell you why. Because that's me. I pray anything I pray. So
right. So in
I might
the
be tempted
moment,
to pray for that person. Yes.
understood. In the moment, the person needs access to tangible resources, right? They need access to something that they can say, if I do X or if I access Y, there is a direct outcome through that targeted intervention. Your praying is helpful, but not in the way that they need at that point in time. When they are experiencing that sense of significant hopelessness, praying actually reinforces guilt and shame. It reminds them that what they have considered or what they are considering is a sin. And it actually reinforces that they are a failure. They fail in themselves, they fail in everybody, and it propels them to engage in the suicide act. What I would say is once their thinking is restored, once they've emerged from the immediate crisis, then you're free to pray with them.
Wow.
I see a hand up, Pauline.
Good night, all. Tonight I had one of the weirdest interactions. So I met somebody from like a past classmate, and I met the person, and I think the first sentence that they said was like, "Girl, right now I feeling to kill myself." So I kind of was taken aback because, with the suicide that it just had, I was kind of taken aback, and like I'm not sure how to feel about it, because sometimes you in your mind, is this person joking?
Yeah.
And I'm not sure if I had that shock on my face, like, we say don't be shocked, but it
Yeah.
was because I normally don't run into the person, and for you to for that to be our interaction, it was a kind of weird thing. So I am like, seeing that would have happened to me, what am I to do in that situation? Like, how would I be helpful to
Do you
that
still
person?
have contact with the person?
No.
So what okay, that's unfortunate. Because what you really should have done in that moment is to ask that question. Are you joking or are you serious? Have you been thinking about hurting yourself? Do you have any plans? Is there somebody that you could talk to about this? Is there somebody you need me to direct you to now? That is what you should have done. And as I said, I know that it's a very difficult load to take on, because you do end up in this freeze response. I would say that it's very significant that the person will have said this to you, because the truth is, many times a person that is having suicidal thoughts will not let the people closest to them know, but they will actually identify to somebody that they have in these thoughts. So the person would have chose you maybe because they knew that you wouldn't do anything about it. It's a way for them to express that I'm having these thoughts, but then, what is she going to do? She don't know my family, she don't know who to call, or she won't do anything about it. Not to say that the person target you specifically for that, but sometimes that does happen where the person does not indicate to their closest relatives because they are worried about how the relative would respond. So they tell somebody else, somebody that is not even close to them or might be distant. So what I would say is it's past. Don't put any guilt on yourself. Don't blame yourself for how you did or didn't respond. It's just being mindful of the fact that a lot of people are suffering. A lot of people are afraid to speak out about their suffering. And so it's always good if somebody does mention something like that to probe. Always probe about it, you know. And if you feel uncomfortable probing, ask hypothetical questions. So if you were to do it, what you would do? And if they say something like, well, I'll drive off the cliff somewhere, drive off Bad Rock or something. But you know that they do have access to a car, they don't even have the driver's license. You might tell yourself, okay, this person probably frustrated, yes, they're probably not happy where they are, but at this point in time, there may be little risk. But if the person say, well, I'm going to hang myself off the construction site that I'm working on Sunday morning when it have no workers there, then is access to a rope easy? Very. Do they have access to the construction site? Yes. Is it going to be lethal? Yes. I will explore that further, and in that moment, I'll tell them they have to tell somebody, or I would tell somebody. And two, I would say that there are times I've had to break confidentiality where this is concerned, and I've had patients or friends that would say, Alina, if you do this, I'll never talk to you again. I had a patient that told me, she came in my office at the hospital. She would have expressed suicidal thoughts. She had a young daughter at the time, and she said, I can't go on the ward. Who will look after my daughter? So I'm there trying to think, okay, taking care of the daughter versus somebody who I believe is at risk. The person at risk comes first. So I said in that moment, I said, listen, I'm sorry, but I'm going to tell the consultant that you're having these thoughts, you do have a plan, and we're going to have you admitted. And she said, if you do that, I'll never come back to see you again. I'll never talk to you again. I'll pass you straight. This is a patient that I was seeing for a while. So we had a therapeutic relationship. I felt very hurt in the moment, and I had to remember the way I demonstrate my care for her in this moment is not withholding the information, but sharing the information. She was admitted. She was very angry with me. And 2 weeks after her admission, she came to my office. She said, Dr. Williams, thank you so much for what you did. I will never forget what you did. And to this day, she's very well now. She's doing excellent. She has a very good job. She has migrated. She's flourishing. And she always says, Dr. Williams, I'm thankful that you had me admitted that day. So even if they're angry and they say, I'll never talk to you, or if you do this, don't make a big deal out of this, a small thing, it doesn't matter. You are not a clinician to evaluate their intention. Let the professional do that. They'll get around to talking to you again. Yeah.
Okay, I was going to ask a question, say something. You mentioned the word, I was saying most men commit suicide because of tobacco. How you explain that word, tobacco? For those who might not know what it means.
Oh, it's like when you get a real heartbreak, like a serious heartbreak. Yeah, when you lose like the love of your life and you feel like you can't go on, that's a tobacco.
Yeah, so most men commit suicide because of that. Now, I think Marjorie mentioned that you could pray for the person, but you suggest they should not pray for the person right away. But if you are led by the Spirit of God, because I believe sometimes you are led to do certain things, you might not get the opportunity to do it again.
Okay, I don't think it was for the person, but with the person.
Yeah, with
Dr.
the
Williams
person,
said, Dr. Williams said that, well, in different words, you can pray for the person.
That's right, with the person, I believe.
But
I believe
with the person,
you don't want to do it in the moment. And you see, again, mental health is very different from physical health too. If somebody was having an asthma attack in front of you, Mr. Charles, right? They didn't have the inhaler. You have no access to an inhaler. This person is having an active asthma attack. Would the first thing you do say, oh, let me just pray for you while you're unable to breathe? It's not the time. You will first try to get an inhaler for this person. Same thing if the person having a heart attack in front of you. They are in the moment having a heart attack. You're not going to pray for them in the moment. You're going to stabilize them. You're going to call 911. You're going to probably do chest compressions to keep them going. You're not going to see somebody collapsed on the ground having a heart attack and say, let me pray for this person right now. You will pray at some point for and with, but
Pray
not
as you
at
pump.
that point.
You pray as
That's
you
what I'm
pump.
saying. You
Another
could pray as
thing,
they come too, maybe. I see Gem's hand up.
Yes.
Sorry, I just
Yes, and
let
Marjorie
us
also
get
had a
to
hand up.
Gem.
I
Hi,
have a
good.
question. I came in late. On the suicide with young people, did you express, or was the thought expressed about sexual ambiguity? People are dealing with sexual challenges and they are ashamed to tell, or they believe they won't be accepted if they tell, or their parents know, or the loved
Yes.
ones know.
So I spoke
Because
about
that's
inclusion
okay.
or discrimination or
Right,
not
I missed
feeling.
that.
Yes,
Okay, because
yes,
I
yes. It
know
is
that's one of
significant.
the biggest issue with young people,
Yeah.
and social media exposing things that they never wanted to be exposed.
All right.
Thank you.
I see Gem has a hand up. She's having it up.
Hi, good night. So my question is, how do you help a child that has suicidal thoughts? The backstory is her parents divorced and she doesn't get to see her daddy as much as mommy. And when mommy is there, mommy beating on her and stuff like that. So her grades deteriorated and, because of that, she stayed down. She not being promoted to her class that she wants to go. She's only 9. So how can I help her?
Help
So
mommy.
I would say based on what you've described, the person should be assessed by a professional, right? What you can do is to be there for the person. And again, we all have to recognize the limits of our capabilities. And we always have to think of mental health the same way we think about physical health. You do your part, for example, brushing your teeth. You brush your teeth every day to maintain its health, to prevent cavities, to prevent gingivitis, etc. But if something happens, you seek out the help of a professional. You go to a dentist. You have an assessment done to determine what needs to happen. And then you take proactive action, whether that means changing your toothpaste to something that is fluoride-based or whatever it is. It's the same thing in a case like this. You can do so much, and the so much is to be a buffer for her, to be her a good model of resilience and coping. But for the work that needs to be done, it really should be done by a child psychologist or a child psychiatrist to assess a lot of what may be happening, to determine risk, to determine if there are other things at play, and to ensure that it doesn't progress to something that is beyond your capabilities.
Dr. Williams, I want to come in here.
Sure.
I'm not vented into your domain. I am
Yes.
just speaking from the perspective of an educator.
Mm-hmm.
This child should be in an age-appropriate classroom. You see, keeping the child at a lower level because she's not performing, well, typically, that is so damaging to a child. And she is already facing other issues. We're compounding it when we say you have to stay, you cannot be promoted. The thing is that educators have to learn to teach children where they are. Every child, children are not all the same. And so we can't assign them to the same futures. We can't assign them even to the same present. What teachers need to do, and they know it, is to find out where the child is and to provide educational experiences so that this child could move from this point to the other. We have to stop comparing them with other children. And when we stop doing that, we will stop keeping them down, as we say. We will promote them because they need to be with their peers, children of the same ages. So the school needs to intervene, or somebody needs to intervene in the school as well, so that this child doesn't feel worse than she's feeling already.
Yes, that is it. You don't want to reinforce the bad feeling that already exists.
And I just wanted to just make a point there. Good night, everybody. As Dr. Ward was saying, and sometimes those teachers doesn't even know how to deal with the situation because they are not, if you notice now, some educators, there are a lot of young people who are coming into the teaching profession. And we are faced with children who are autistic. And we realize that a lot of teachers doesn't know how to deal with children with those kind of issues. So I think we just need to look into that, especially when you're going to do have that profession. You need to educate yourself so that even when you are faced with that, you know how to deal with the situation. I just wanted to touch on something. Society, when we look at society sometimes determine our outcome in life. I would have, I was telling my husband recently, I said, look at this. A lot of young people look up to some people as mentors, even in the government sector, even in the parliament. I look at that. They have them debating in parliament, and the behavior of some of the youths is really, really sad because they are actually looking at the adults in parliament, how they behave, how they treat each other, how they call each other names, and it affects society in a really, really big way. And sometimes when we see some of these problems being bullied, it stems from all those kind of behaviors, because I call in your name and I don't like you because you don't do it the way I do it, and you don't say it, you can't read like me, and you can't present like me. And we as society, we actually start the whole problem with our young people to get out of hand, and they start doing these things. And then when they come to a point in their life when they can't deal with it, they can't talk to somebody about it because that is what they're being taught. And we see it just spiral out of control. How do we handle that? Because we're seeing the adults doing it. We see people doing it in the government, in the parliament. And we see the young people doing the same thing. So how do we help these young people? Because we are the problem. We create the problem. And so when the problem happens, how do we deal with it? Because we're supposed to shape these young minds.
But Sherilyn, this is why we exist. This is why Hope and Action Network exists. Remember, our vision is a better society built on strong foundations.
Yes.
Through the empowerment of everyone. So when we come here on a Wednesday evening, whatever we do is aimed at empowering, building a better society. So it might appear as though we're just moving inch by inch, or maybe not even an inch at a time. But we are trying, and there are other organizations that are trying as well. But what we will continue to do is to speak out against the negative side.
Yes, that's right. That's right. That's
right. And we can't be ashamed. We have to
not
be brave and continue to push. And if we could convert one, we'll be happy. We'll be happy.
Right. So thank you, Dr. Williams. Yeah. Thank you very much, Dr. Williams. On point. I
Thank
don't
you.
envy you. I don't envy you in your corner too.
Yeah.
Yeah, with great
She's able.
presentation.
She's able.
Thank
She's
you.
able.
Yes.
So, it has been a long time since we've gone to 10:45. We normally
Wow.
close off a little after 10, 10:30, perhaps for the latest. But this has been so interesting, Dr. Williams. I don't know if you have
Thank
any
you.
closing remarks, if you had anything else that you wanted to say to us. But if
So, no, I really just wanted to highlight again that we all have mental health and
yes,
that we all need to take care of our mental health the same way that we take care of our physical health. We all do small things day by day to take care of our physical health, and we need to give that same sort of attention to our mental health because we never know when we will be at risk or when this, as I say, the straw that break the camel back. We don't know how close we are to the edge at any point in time. We need to be mindful always. And never say it will never be you.
that's right. That's right. Yes, we all have mental health. Dr. Williams, this has been so educational. It has been so profound. It has been so deep. We are going to remember what you did. I usually look at the recording, so I'm going to look at it perhaps before I go to sleep tonight. I'm going to look at it again. There's so much information provided. And of course, you did it in your own calm and, soothing kind of a way. But it is
Thank
truly,
you.
truly excellent information. Thanks again for agreeing to come on when I asked you to. I see the people dropping off now because they realize that we're wrapping up. We thank all who participated this evening. And we encourage people, this recording is going to be on YouTube and Facebook. Please share it. People need to know. People need to understand. And hopefully, people will begin to view mental health more seriously. And they wouldn't think, the minute they hear mental health, they think that is mental illness. You're mad. You're going to sit dance. You're schizophrenic. We all face problems at some points in our lives. And I noted especially that you gave us the 4 stages. Healthy.
Yes.
And even when we're healthy, we have the normal mood fluctuations, you said. Then we can to reacting. Reversible. But we can become injured. And there's where we have the significant functional impairment, followed by the illness, clinical disorder. The clinical disorder. Dr. Williams, this is valuable. We can't put a price on it. And we thank you so much for being up with us. It's almost 11 o'clock, but you took the time. And I'm sure all the participants are grateful to you for that. Come again, people. It's the same link every week. And every week we discuss a very important issue. Next week, I plan to deal with independence, what it means to all of us. However, if I notice anything trending that is more serious, I will deal with that. Because sometimes we are reactive. We plan ahead, we have topics lined up, but sometimes we notice something happening out there that we need to speak about. So come again. Thanks. And remember to share the link, share the invitation, share the videos. We want
Before you go, Dr. Williams, how do you, I don't know if there's any system set up to address the issues of divorced parents with children, because we live in a society where parents take out their frustration on one another and the hatred of one another at the expense of the child or at the expense of the children. Is there any way or any means that there's counseling for these individuals?
Yes, so there's counseling available at the Division of Health, Wellness, and Social Protection. There's actually a therapeutic counseling unit, but outside of that, within the division, they also have parenting workshops And these parenting workshops are twofold. One section caters to parents that are together but struggling with parenting. And then there's the second section that deals with parents who are no longer together and sort of navigating co-parenting relationships. So there are a lot of options available within the division and programs as well within the division for that.
And thank you for the process where you talk about what we can do, because a lot of people don't know what to do.
Indeed.
When someone voiced, or you see that someone is acting suicidal.
Yeah.
If you're not clinical, you don't know. But there are a lot of everyday mothers and fathers who are seeing signs that they don't understand. Thank you for that.
Yes, you're welcome.
Thank you. Thank you.
I would say for mothers, for parents, withdrawal is one of the biggest signs you want to look for.
Sign, locking
A
themselves
child that
up
is staying, in their room
Mhm.
constantly. Yeah. With changes in appetite and sleep, of course.
Yeah.
And schoolwork. Interest in their friends.
Yes, it shows in the
Sometimes
schoolwork.
we are just so busy we don't pay attention. Thank you so much. Thank you.
Okay. All right. Thank you, Dr. Ward, for this opportunity. And thank you, everybody, for paying attention and for listening. I hope everything was well explained.
Oh, yes. Oh, yes. It was extremely clear. Thank you so much.
Thank you.
Thank you.
All right.
Right. So let me just say a short prayer as we close. Heavenly Father, we thank you for Dr. Williams and all the information that she shared with us this evening. We pray, oh God, that you continue to be with her as she executes her duties. We know that this is a very stressful kind of profession, but we know, God, that you have empowered her. You've given her the knowledge, the attitude, and the skills that are required. So continue to be with her, continue to guide and lead her. And we pray, oh God, that as we have received this information, we'll share with others so that we can help them as well. Give us all a pleasant night rest, we pray. Wake us up tomorrow, willing and ready to serve others. This is my prayer in Jesus' name. Amen. Thank you, everybody. Have an awesome,
Thank you.